Even though perhaps you've already read about him, Dr. John Olver is a consultant physician in rehabilitation medicine and for 25 years was Medical Director of Rehabilitation at Epworth Healthcare in Melbourne, responsible for the inpatient and outpatient rehabilitation of patients with traumatic brain injury, including concussion. He is Director of the Epworth Monash Rehabilitation Medicine Unit. Please welcome John.
Thank you very much, Nick, and thanks for the invitation to speak. The focus so far today has been on acute management and recognition of concussion. In 2016, in response to increasing demand, we set up a clinic that basically wanted to focus on people who had persisting symptoms. It's now called the persistent post-concussive symptoms. It has been called post-concussion syndrome in the past. So whilst we see people in the first week or two after concussions, this treatment program was aimed at people whose symptoms persist. And the cut-off point has varied over the years, but it's generally taken in the literature now as greater than 4 weeks. So if we look at the definition of concussion, I'm not going to go into this again, but I just want to highlight 2 things. First of all, there are approximately 20%, 15 to 20, in some articles 30% of people with acute concussion that will go on to have persisting symptoms, and these are the ones that we're targeting. The second thing is that the world literature at the moment says that associated with concussion, 10 to 20% of people will be knocked unconscious as a result of the incident. So I just want to, from the outset, point to some of the statistics I'll be showing you today from our database. And we've now, since 2016, seen our 1,000th patient. So we've got quite a few records of outcome in that time. Our rate of problems with people being knocked out is 40%, and that's because 20% of our patients, because of our treatment of traumatic brain injury, come from motor vehicle accidents, because we treat the moderate to severe traumatic brain injury. So that's the only difference in our cohort to other cohorts. Now, why do we get persisting symptoms? Well, there's no one answer to this, and there's no research that'll give all the answers. But we know that there's an initial metabolic disruption, as been shown in some of the earlier slides, after concussion. And we often sort of tell our patients that concussion is really a software problem, and more severe, moderate to severe traumatic brain injury is probably more of a hardware problem where you get actual damage to neurons. And that's not to say you don't get damage with concussion, but it's more the software, the metabolic changes. And we've also heard about these autonomic changes, the rapid rise in blood pressure, or the rapid rise in the rapid rise in pulse rate when you start to exercise someone. And sometimes these autonomic symptoms don't turn off in the first 4 weeks and lead to ongoing problems. And we've heard about the importance of neck injury. In any of the checklists post-concussion, we can see that about 1/3 of the symptoms can occur just from having a neck injury without necessarily a blow to the head or a deceleration-acceleration component. So we need to recognise that a lot of our concussion patients will also have their symptoms that may be primarily due to neck injury. So things like, headache, numbness and tingling in fingers and toes, dizziness, vomiting, visual problems, etc. The other cause is the psychological component. A past history of anxiety, depression, stress disorders, can lead to symptoms that should have improved getting progressively worse. And also, we know that if you've got profound problems with vision, and I'll go into that in a few minutes, and balance, then these items take a lot longer to treat and to help than some of the other things on the checklist. So again, these are things that can lead to symptoms progressing for more than the 4 weeks. So what contributes to these sort of symptoms? Well, I mentioned a number of pre-injury things, but intellect, anxiety, depression, problems with resilience, your beliefs about brain injury, previous multiple concussions, female gender, and I think we're going to hear more, well, I know we're going to hear more about that this afternoon, but there is a difference related to things like neck girth, related to progesterone, related to females being more honest than males in reporting symptoms, and there's a number of other things that we'll leave for this afternoon that make it worse. And it's been very good to see some of the, as Michael mentioned, some of the AFL, particularly AFLW clubs, now concentrating on building up neck musculature to improve this problem. And other problems in the past with learning difficulties and attention disorders can make symptoms magnify after a concussive illness. The injury itself may be important, the type of traumatic event and the experience, the post-traumatic stress disorder relating to a lot of injuries. We've recently done a study looking at our patients who have not had traumatic brain injury of any sort, but have just had multi-trauma orthopaedic problems, and found quite clearly that their psychological distress, when we measured it, is much greater not only during their rehabilitation, but for some time after. And we now need to put in place programs that will help them deal with that. We underestimated it. You'd always have a psychologist in a brain injury unit, but in a multi-trauma orthopaedic unit, not everyone gets psychological input, and our study showed that just about everyone needs it. And then we've talked before about why symptoms persist, and sometimes it's incorrect advice early. You know, you'll be right in a couple of weeks, but no further appointments. And then after 3 or 4 weeks, when they're not right, they don't actually know who to turn to for help. And sometimes concussion can go alongside other illnesses, and the progression of concussion can mask the other illnesses. So just because someone's had a concussion doesn't mean that that's the sole reason for the symptoms that sort of persist. Also, lack of success in your rehabilitation, putting people back to work too early, or putting people back to sport too early can actually have a negative effect on their long-term outcome. Now, for those of you who had something better to do on a Saturday afternoon, this is the total picture of what it takes to deal with concussion. And I've dealt with moderate to severe traumatic brain injury now for just over 40 years, and I've found dealing with people with concussion much more problematic and much more difficult. I was saying to someone the other day, it takes me about 45 minutes to assess someone with moderate to severe head injury. It takes me about an hour and a half to properly assess someone with concussion. Don't take notes, I'm happy to give you this slide. Now, the multidisciplinary team model is what we set up for these people with persistent symptoms. And when we started, we had a rehabilitation physician, 2 physios, one who knew something about vestibular or dizziness, vestibular dysfunction, dizziness and balance symptoms, and another one who was an expert in treating the neck. And we also had a neuropsychologist who, thankfully, was also a clinical psychologist, because we have found in the first 1,000 patients that we might have done 40 neuropsych assessments, but most of them have needed clinical psychological input. Over the development of our clinic over the last 7 and 8 years, we've now added exercise physiology, and that was because we got a lot more sports people needing return to work, and they do the high-level testing, which I'll talk about. We've now added speech therapy, vocational occupational therapy, which has now come occupational therapy to look at return to driving, which has now come occupational therapy looking at how people organise their daily activities, the basic, what they call activities of daily living, to get back to work. And we've just recently added a dietitian, and there's more papers now coming out on dietary concerns after traumatic brain injury. But what we found, without looking at any special diets, is that after concussion, people with persisting symptoms either lose weight or gain weight, and we've got to do something about it. What is the source of referral? Well, when we started, we imagined that most of our referrals would come from emergency departments as a sort of a follow-up to the 4 hours of surveillance when they come in after their acute concussion. But this, in fact, wasn't the case, and 68% of our patients come from general practitioners who are the ones that are still treating the patient who continues to have ongoing problems, not necessarily the specialists they see early. Although we do get 10% from emergencies, neurologists, sports physicians and others. Now, we started our clinic, somewhat regrettably, between SCAT4 and SCAT5, so we had to look at another concussion tool because we didn't know how much SCAT5 was going to change, and it did, I think, considerably from SCAT4. So we found the Oregon post-concussion symptom checklist and a bit of research that went with it. So we adopted that. They're all about the same. So this has 23 symptoms. They're grouped into physical, thinking, sleep and emotional, and they're rated, self-rating by the patient, between 0, I don't have the symptom, and 6, it's severe. And we do this at least on initial assessment, which is usually by the rehab physician, and on discharge, which could be the last therapist seeing the patient, or again the rehab physician. And the orange circles on this graph are the scores in this particular patient at clinic admission, and the blue were clinic discharge. And the point that is made slightly here, but I want to make and will make further, is that we never promise anyone that they'll be symptom-free by the time we get them back to work, back to sport, etc. And it was good in the consensus statement, the recent one, that now if you're doing some high-level activities in preparation for getting someone back to sport, you can now have mild symptoms and still go ahead with the activity. That's what the evidence shows. In the past we've said, well, any symptoms and that's it, you can't go back. So that's been very helpful to us in getting people back to sport. The other useful thing, and we didn't know how useful this was, that we found with this particular questionnaire is that it had a single question. Compared to 100%, which is what you were like before you had your concussion, what's your overall activity level today in terms of work, school, social activities, everything you do? And the patients have reported that, and we'll show you some of the results from our database. And remember, this database is all Victorian data. So let's look at 800 of our patients, or 880. Their mean age 37.9, roughly half-half male to female, whereas with moderate to severe head injury it's 2 to 3 to 1 male to female. A long time to clinic post-injury overall since 2016, now thankfully getting shorter and shorter, and I'll show you why that's important, and Michael's already alluded to it. First concussion, 55%, loss of consciousness, 42%, compared to the 10 to 20 in the world literature. The employment status, similar as normal. The cause of injury, we're a bit biased towards motor vehicle and bike accident, but sport, 22%, falls, 14%, that's at home, workplace, 13%, and assaults, 5.1%. So again, domestic violence, that figure is regrettably increasing as we understand it. So from our data, this gives you an idea of the top 10 symptoms on clinic admission of this now large group of patients. And you will see that the second and third one, which is fatigue and feeling slowed down, are also cited as the generalised factors in moderate to severe traumatic brain injury. That's slowness and fatigue. Why, if difficulty concentrating is one of our main presenting symptoms, do we do so few formal neuropsych assessments? Because problems with concentration are multifactorial, and in concussion they're rarely due to damage to the, can I say, concentration areas of the brain. They're due to fatigue, they're due to anxiety, they're due to headache, they're due to dizziness. And so it's not really useful until you get those things sorted out to say that someone has an ongoing concentration problem because of organic damage to the brain. Again, software versus hardware. Dizziness was further down the list than I thought it would be, but it's still in the top 10. Feeling more emotional. Headache is number 5. And this one from the Oregon list, feeling mentally foggy, that's become now a catchphrase of long COVID. So we're very well familiar now with this, people complaining of this generalised fogginess. So what do we do? Now these patients are not getting better when we see them. In fact, they're getting worse at the 4 weeks and 3 months and 6 months, and we've had referrals up to 5 years post-injury. And what this graph shows us is that if we look at the light blue, this is their total score on the checklist on admission, and we look at the score on discharge, in all areas there's a significant difference with the therapy that's given. Now I'll point out that we don't target the 23 symptoms. We may target 3 or 4 of them, and turning off those will turn off most of the rest. And the expertise of people that have been dealing with a lot of people with concussion is to know which symptoms to target. The interesting thing is, if you look at the bottom statement of that box on the side, people's daily activity levels when we first asked them were about 42%. I can do 42% of things I used to do 4 weeks ago or more after my concussion. And when they're discharged, they're reporting 76%. They're not reporting 100%, but the headache at the end of the day, the slight slowness, hasn't stopped them from going back to work, or they've been able to manage to go back to sport. Having said that, a number of people who have been fine going back to sport have given it up because slight slowness has meant the difference between being elite and not quite getting there. This was particularly the case in one of our jockeys who was very, very good, but he told me that the thing about being a jockey, as he told me, was picking the gap, getting through it, and that was instinctive. He was a split second slower, so he didn't win as many races as he used to win in the past. It wasn't as satisfying, so he gave it up. Same with football, we found that as well. I can't judge the ball as well, I can't read the game as well, so that can be a problem. So what are the risk factors for prolonged recovery? Well, past medical history, particularly of migraine or mood disorder, if we get people with high initial symptom scores, we know that their symptoms are going to be difficult to treat. Time to presentation is particularly important. The longer it is, the worse we do. And in all compensable, and I'm not just sort of saying TAC with TAC work cover, in all compensable cases, and this has been reported in the literature, people don't do as well. And what we've found is that they tend to be referred later. They've also got some financial incentives with loss of earnings not to be as urgent to go back, and there's probably a lot of other factors that we hopefully will find out about over the next few years. Gender, we'll hear about that later. Level of education, the lower your level of education, the less spread you've got of getting back to modified work. so people don't do as well. And the older age you are, apart from the fact that you've got a lot more experience in things, and that's an advantage, everything else is pretty much a disadvantage. What are these persisting symptoms? After being through our program for 3 to 6 months, all outpatients incidentally, what are the persisting symptoms? Well, fatigue is still reported by about 40% of our patients. I'm back at work, but I don't make it through a day as well. And that happens with age too, as I'm slowly finding. Visual problems. Now, visual problems, and I'll talk a little bit about this, but visual problems very different after concussion. I've got an eye chart on my wall which I rarely use, mainly due to lack of time with concussion patients, but it's all about motion with concussion. You know, I get dizzy in a car when my eyes flick from side to side. I can't look out the side window of a train, following objects and then the eyes flicking back, the saccadic movements. So when we test vision, in the initial time, we test all the movement. The vestibulo-ocular reflex, big words, but the issue is that you can't mark a ball in football. If you're moving, the ball's fairly stationary and your vestibulo-ocular reflex isn't working, you won't go anywhere near it. So we test that from day one, and that's where our physios and our optometrists can be helpful in trying to re-establish that thing. And there's two symptoms there, numbness and tingling, and pain other than headache, which is mainly neck pain, that again have the importance of the neck. A neck is very difficult to treat, and I'm pleased to see that our prime neck physio is here today. She's not going to learn much from me, but you know. So what are the predictors? Well, late referral, as I've said, 38% of our patients have a late referral, whereas 60% of our compensable patients of all types have a late referral. We haven't found too much difference in gender, though we appreciate the changes in our first sort of patients. But we know that each additional symptom at admission was associated with an increased risk of at least having one of the 5 persisting symptoms on discharge. And this is referral time by discharge outcomes on all of the things. And so the late referral group displayed significantly increased total subscale scores. And we've found that people in the late referral group say that their 68% have got a problem in 68% initially compared to 100% of their activities before, compared to the early referral, they have 68% on discharge, whereas the early referral group get up beyond 80% on discharge. So again, they just don't do as well the later. And the main reason for that, that our research showed us, is psychological factors. Now, neck problems I won't go into, but I just want to reinforce what Michael is saying. It is very, very important. Vestibular rehabilitation, balance and dizziness. The dizziness is the thing that patients complain about worse. They seem to be able to tolerate migraine, but if you're dizzy every time you turn your head during a day, that's a major symptom. And that's why we spend a lot of time with specialist physios looking after that. And as I mentioned, the vestibulo-ocular reflex, this sort of tracking a ball in motion, either while you're in motion the ball isn't, or vice versa, is very important. So vision testing to us is all about motion, either not being able to track objects or having problems when motion is going past you. One of the chief things is this thing called benign paroxysmal persistent vertigo, BPPV, and this is the main vestibular problem after concussion. And the main feature of this is that even when you think it's gone completely, it can come back 2 or 3 years later. However, the habituation exercises that the physio gave you initially will work later as well. I'm not going to talk about post-traumatic headache, but this is a significant sign, and we know that it's more common in females and males, more common with a history of migraine, more common with a history of mood disorders, and more common with prior concussion. This is again of the persisting symptoms. Post-injury, it doesn't seem to be related to the impact characteristics, but it's related to a greater initial symptom burden. It often has a neck association and often worsens with physical exertion. And these are the visual systems, so double vision, problems with reading, tracking objects, headaches coming earlier, light sensitivity, eye strain and fatigue, and therefore as part of the tripod of balance, vision is very important. Now, anxiety and depression is also important. On admission, 50% of our patients talk about anxiety and 60.7% talk about depression. So again, a lot of our program is set up with clinical psychological involvement. I won't go into this, but it's interesting to see if you compare anxiety and depression to the normal population, how much greater it is, the top graphs on anxiety, depression and stress after concussion. And this is a paper Izzy published in 2021. And anxiety particularly is important, and we use a lot of techniques, but mindfulness is one of them. And if you teach someone mindfulness, how to ground anxiety, because anxiety is not what happens, it is often caused by what's going to happen tomorrow. So I was anxious about this talk yesterday. That was a total waste of my anxiety. It should have been today. So I should have grounded it with the techniques. I'm not going to talk about anxiety resumption because Michael's already mentioned that, but it is pacing, it is not rest. And there's a clinician in the United States who's been in front of congressional inquiries, and he says he lets patients rest for 24 hours, and that's because he thinks he'll be drummed out of town if he can't. But he says start immediately, graded return. And this is the key, graded activity, slowly increasing, 10% a week, 20% a week, everyone's different. So we have a grading system for return to sport. We use a thing called the Gadsby-Goodman test, better known as the Chicago Blackhawks test, and this is a very high-level activity, and if they get mild symptoms or none with that, then they can go back to football, for example, and then it's up to the club to say they can go back, but you've still got to watch symptoms on tackling and bumping drills, etc. One word on CTE and then I'm finished. We still don't know too much about it, and really not much came out of the system. We know that it's been known in boxing sort of for many years. We've seen a couple of them on the program, or have we? We've certainly seen elderly people have had multiple concussions with dementia. And the last thing I want to say is that in the literature now we're starting to hear about subclinical concussion. So is it related at all? Is CTE and other long-term effects related to the number of concussions? And the answer is probably not. The average American footballer at the highest level, it is said, has 1,000 subclinical concussions in a working lifetime. So that means that they've probably got very few concussions recorded because they haven't got the acute symptoms. So the heavy knock that doesn't lead to concussion may be as bad if you have enough of them as concussion itself. Thank you.
Now, the last thing that I want to do is to hold you back from your caffeine fix or your sugar high. So unless there's a burning question that simply can't wait for the panel discussion, we'll take just one.
Hi. Does litigation have an effect on outcome of recovery and persistent post-concussion symptoms?
In terms of persistent symptoms, we certainly get a number of people that go to litigation, but it's usually quite late, and it's usually about return to work, or it's usually about loss of payments from insurance relating to that sort of thing rather than the symptoms themselves. So yes, we do see a lot of medico-legal work, but not nearly as much as we do in moderate to severe brain injury. So I don't relate it yet in the ones I've seen to the concussion and concussion symptoms.
Please thank John.
Enjoy your afternoon tea, and we'll